Good evening, everyone. Thank you for joining us for another fabulous edition of My Sister's Circle. And today we are talking about navigating medical and insurance coverage. This lady needs no introduction. She's the spokesperson for My Sister's Keeper. She is my older sister, Miss Demetria White. So we were just talking a few moments ago. Back in the 90s, she was a financial counselor. But she has an extensive background in reimbursement, medical insurance, ranging for working at Cleveland Clinic and University Hospital. She is currently an administrator of Pediatric Institute at University Hospitals. She has her master's in business administration. And I don't know what else to say about her because everybody knows everything about her.
My bachelor's is in healthcare
Business
administration.
healthcare administration. Oh,
Yeah.
okay. Well, so without further ado, please allow me to introduce you my sister, who is the presenter for this evening. Tell us, Demetria, anything else you want to add about yourself that I missed? I know I missed a whole bunch, but I gave you a very lengthy bio on our page.
Oh, well, good. Well, thank you so much. Well, no, I mean, we only have an hour and and thank you for inviting me. And as you said, I'm always somewhere talking about My Sister's Keeper Cleveland, but today I'm switching gears in a little bit of a different capacity. I'm here on official work assignment, and I kind of get to share with you guys a little bit. There's tons of information, and as we know, insurance regulations, policies, procedures in regards to healthcare is constantly changing. So I am not going to sit here and say this is the have all be all. What I chose to do today was to keep the presentation very, very basic. This was something that Sherry felt was a need for our sisters. In their quest to be their own advocate. So being a patient advocate certainly does include taking care of your financial healthcare finances, as well as making sure that you are not going bankrupt due to your health and your insurance struggles. So without further ado, I am just going to go ahead. Pardon my PowerPoint. I was telling Sherry, I sit on some of these, and some of you guys have really amazing PowerPoints. And I promised when I got out of school, I wasn't doing no more PowerPoints. So I'm limited to what I have to do on my real job. So let me start sharing my screen. Oh, let me see. Hold on, I'm gonna stop share. I was testing things out, so let me get where I'm supposed to be before I share. Apologize. All right. All right, you guys can see my screen, correct? All right, thank you, Sherry. Thank you for taking the side notes off. Ha ha ha. All right. So again, as Sherry said, my name is Demetria White. I am here to discuss navigating medical and insurance coverages. So I'm going to give you some real general, real broad information, but I promise you, I am going to cover as much ground as I can. What I really do feel is necessary in understanding and knowing in our ever-changing healthcare business side of things. So, what the reason I think I have so much passion about this is because I really believe that our community has a really general distrust of providers, of hospitals, and feeling as if, many things are about money. But I want to kind of change your perspective a little bit today. When it comes to money and healthcare, I probably am more of the person you want to look at, and not your provider, not your healthcare provider. And I'm not saying that they're not out there, but people like me exist so that your providers do not have to worry about being reimbursed and paid for the services that they're doing. So let's go ahead and get started. So insurance coverage. Insurance coverage comes in there's levels to insurance coverage. So I want to talk about how you get insurance coverage if you don't have insurance coverage. So probably the most common is obtaining health insurance through your large group employers. Large group employers are usually about 250 people or more. It's probably less than that these days because with the Obamacare Act, it has been regulated that even small businesses have to offer some type of coverage or allow some type of benefit in terms of health insurance. And as you guys know, health insurance was also, signed into law. Don't know if they're penalizing as much right now in terms of taxes, but I do know that they're still monitoring. I do want to share for those who do not have health insurance currently that the healthcare marketplace is still, I think the open enrollment has opened and you have until December 15th. If you don't have any health insurance, you have until December 15th of 2023 to sign up for benefits for 2024. What I will say is the healthcare marketplace, I kind of fiddled around in there just to kind of see what was out there. But there is a wide range of commercial insurance plans. There are some Medicaid plans. Some people choose to kind of lean toward the Medicaid plans because they do have a tendency to be less expensive. You are paying out of pocket for these on a monthly basis. So, that is something you want to keep in mind. But I do want to say, too, what some people don't realize until they actually go in to look for insurance is that if you work for a large group employer, and they offer a healthcare benefit package, you are obligated, should I say, to take that plan over searching for some cheaper options on the marketplace, because I do know that is something that they will screen for and ask. And I think you can just go out there, www.healthcaremarketplace.com. You will see, I don't know if there's one standard website, there may be, but you will see a lot of different insurance plans offering information. And again, that deadline is December 15th if you are looking for health insurance right now. Another common insurance coverage that we see a lot is the Consolidated Omnibus Budget Reconciliation Act of 1985, which is also known as COBRA. I put on here is kind of a gap insurance. So when we hear of gap insurance is where one coverage ends and kind of covers you for a period of time until you can get new coverage. The COBRA insurance is something that, if for whatever reason you happen to be laid off from your job, whether it's a temporary layoff or a permanent layoff, they will offer you a COBRA plan. I don't know of many people that take advantage of these plans because they do have a tendency to be extremely expensive. And if you find yourself in this type of situation where you're going to run out of insurance because of your employment situation, I would steer you toward the healthcare marketplace, if you're within that open enrollment period. Government plans. So our government plans are, there are eligibility requirements for our government plans, and those are our Medicare and Medicare HMO plans and our Medicaid plans. So they are federally funded. Medicare requirements are generally 65 and over. There are people who can kind of get Medicare benefits a little bit before 65 if they retire. But I know if you wait until you're the age of 65, you get full coverage. 80/20 is what they generally cover, but you have more options. Also, what you want to be mindful of with your Medicare HMO plans, some of those plans are very good. They offer, a lot of people find them attractive because they do offer more coverage in terms of your prescriptions, lower copays. They offer more screening opportunities. Medicare is very rigid. And there's an 80/20 coverage that cover 80% of what they consider medically necessary, and generally 20% of whatever your hospital finances are will come out of your pocket. So a lot of people do lean toward those Medicare HMO plans because it allows them a lot more wiggle room, especially if you're a person that has a chronic condition and you tend to go to the doctor more often. There are some prescription plans offered by Medicare. It's through the Medicare Part D plan, but you would pay in addition to, you're paying for that benefit. It's not something that's generally offered for free. But I also want to make this stipulation for people who are kind of looking at a Medicare HMO option versus Medicare. Generally, you are signing over your Medicare rights, so to speak, if you sign up for Medicare HMO plan. So I would encourage anyone who is in that bracket, that 65 and over bracket, or almost at that 65 and over bracket, and you're kind of weighing your options, please do your homework. Find out which one of those options would be more cost effective for you. Again, if you're a person who has a lot of prescriptions, those HMO plans do kind of cover a whole lot more and give you a lot more wiggle room. And again, less out of pocket beyond your copays. Our Medicaid plans are generally set aside for people who are below the federal poverty line. And they also cover people who are disabled. And I should have also said that about Medicare. There are some people who are eligible for Medicare because of a disability, and they're well below the age of 65. But if there's a disability and you're below poverty line, Medicaid plans are generally something that you can qualify for. What's good about so Medicaid plans, I'm going to tell you the plus and the minus. The plus side of a Medicaid plan is, again, because you fall within a certain poverty guideline, your out-of-pocket is nothing. And when I say nothing, I'm talking specifically about medically necessary services, and I'm going to get into that a little bit in a few minutes. So there's no out-of-pocket for medically necessary services. So you don't have to worry about what's my copay, this and this and that. Generally, the providers are not coming after you after the insurance company pays their portion of whatever that contracted rate is at the time. There is no copay out of pocket generally for the patient. So that's the plus side for the patient. The minus side is it works kind of the same way as the Medicare plans. You have your Medicaid, which is Ohio Medicaid in our case, and then you have your Medicaid HMO plans, which work the same way. They kind of give you a little bit more wiggle room in terms of services, screenings, providers within the network. So you do have a little bit more of a wiggle room. I will say, from the last I remember, if you are switched from a traditional Medicaid plan to a Medicaid HMO, it's generally not because you wanted to. It's generally because your caseworker has chosen to put you on a Medicaid HMO plan. For all intents and purposes, it doesn't really make any difference. What you have access to in terms of coverage will remain the same. But I will say that it does exclude you from certain providers who may not have a Medicaid contract. It will exclude you from probably some of those services that may be on the side of cosmetic, not medically necessary. So wanted to just kind of braze over that a little bit for the Medicaid plans, because just because you have a Medicaid insurance does not mean you can just go to the doctor and have whatever you want, at no expense. So I do kind of want to put that caveat out there. So I want to talk about uninsured versus underinsured. It's a little bit of a difference. So uninsured means you have absolutely positively no insurance at all, no commercial plans, no Medicaid plans, no anything. So you're considered in the healthcare industry as a self-pay person. So all of the services that you would acquire or accrue throughout your treatment will be 100% out of your pocket. What I will say is, if you are in the position to make payments for your services ahead of time. Some people are. You are generally offered a prompt pay discount. A lot of facilities will offer somewhere, I think UH is like 25%. And it kind of depends on where you're going and where you're being seen. But there's a prompt pay discount if you're willing to pay for your services upfront that day at the time of service. So they'll generally write you up an estimate, let you know what that is, and you'll make that payment. And prayerfully, there's no balance bill, but it does depend on what services may be added on after your estimate has been given to you. So I do want to put that out there. Our underinsured usually falls under our Medicaid or our government plans, where there's a large portion of your bill that does fall to the patient that is considered out of pocket. So in the cases of Medicare, again, generally there's a 20% portion. If you're a traditional Medicare patient, you may be subject to deductibles and copays and things, even with with your Medicare HMOs. With Medicaid, it's no out of pocket necessarily, but there may be services that are excluded from Medicaid. So you have a right to know what those services are. So it could be diagnostic tests, it could be treatments, but if they're excluded from coverage for Medicaid, your provider can charge you out of pocket. And in that instance, you would be considered underinsured because you wouldn't have insurance that would be active or considered, for your services or your treatment for that time. Cosmetic services are generally just that. You do have providers that offer things that are considered cosmetic, and cosmetic are services like, could be plastic surgery. There are some dermatology services that are considered cosmetic. There are some dental services that are considered cosmetic. And cosmetic, basically, long of the short, is a service that's not covered or considered not medically necessary by your insurance plan. So you can still have a cosmetic procedure and end up paying out of pocket, even if you have insurance coverage. So again, if you hear the word cosmetic, if that's exactly what they're trying to say to you. Non-covered falls into a couple of different categories. So non-covered means just that. Your insurance company is not going to cover the service. It could be a service that your provider is recommending. It could be a medically necessary treatment, but for whatever reason, your insurance plan chooses not to offer that benefit. Or it could be one of those, I don't want to use the word boutique. I hate boutique, but I'm going to say one of those boutique services that your provider may offer you that they know is excluded from general insurance plans, and then they actually set it up where you have a self-pay or completely out-of-pocket payment for service, and there's no insurance involvement. You pay upfront for the service, you have your service, and that's that. Also, with non-covered, it could be I'll say something like reproductive endocrinology treatments, which, these are treatments that generally are offered to patients who are unable to conceive on their own. Generally, the diagnostic services associated with that are covered by your insurance company. But once we get into the treatment, this is what the provider is recommending, things like in vitro fertilization, artificial insemination. This is just as an example. Those could be considered non-covered by your insurance plan, which you would end up paying for those services out of pocket. Sherry, I want to offer, before I move on to my next slide, any questions that anybody might have before I move on?
I do not see any questions in the post, but Ms. Quenisha said that when you were talking about the coverage discounts, Cleveland Clinic offers 35%.
Okay.
But no question.
Okay, awesome. 35% at the clinic is 20. It's generally 25%. And I will say too, and when I give that number, I'm really talking about the outpatient doctor's office side of business. Generally, if let's say you're having surgery, it could probably be a greater discount if you have no insurance. And I'll get into that a little bit more about them offering estimates and things like that. So here I am, avoid out of pocket. So when we talk about out of pocket is that portion that the patient will be responsible for. So we're talking about your co-pays. So if you look on your insurance card, generally they'll give you a fee for what your co-pays are. It'll have your doctor's office. If there's a PCP copay, generally there's not for your PCP. If there's a specialty, meaning if your PCP refers you to OBGYN or urology or some other specialist, there's a probably a little bit of a greater copay for those. But copays, I do want to say this to people. If you're complaining about, hey, I go to the doctor every month, my copays are adding up. Is there some way that you guys could write off my copays? Copays are not negotiable in terms of what your provider can and cannot collect from you. If your provider is contracted with your insurance company, they are obligated to collect your portion from you. So the contract says, let's say you have Anthem Blue Cross Blue Shield, it's probably called something else now. But if you have Anthem insurance and Anthem says, hey, we cover 80%, and 10% is patient responsibility, and the other 10% is contract negotiation. So that they're going to write off the top. And that's just an example. Usually it's a little bit more than that. That copay amount that your insurance company says you are obligated to pay, you must be billed and you must pay. Generally, they try to collect that copay at the time of your service because they generally do know what that copay is going to be because it'll be right there on your card. But if you don't pay at that time or you don't know what your copay is and they choose to bill you later, you'll receive a bill and your provider has to bill you for that. Your deductibles are shared responsibility. And what I mean by shared responsibility, it kind of works the same way. It's a contractual obligation that your insurance company may have with both the facility and also with you as the patient. So when you go to look up your large group employer plans, and I forgot to kind of hone in on this a little bit when we were talking about getting coverage through your large group employer plans. Generally, they will offer you different levels. Like you'll have the PPO, and then you'll have the health savings, high deductible plans. And kind of depending on your socioeconomic status or your family situation, some people may just go with the basic plan that's cheaper because they have more family members to cover. It's less out of pocket, less of a deductible. Copays are reasonable. It offers them, what they need in terms of in-network providers and access. And then you have people who choose a high deductible plan, and these are the people who probably don't go to the doctor a whole lot. They can save a boatload of money on the front end in terms of out-of-pocket copays, et cetera, et cetera, et cetera. But if for whatever reason they do have a hospital bill, their deductibles can be extremely high because they're saving the money on the front end. So I encourage you to kind of do your homework, weigh your options, see which one of those work for you. Because again, you end up in an emergency room, or you end up having surgery, or you end up with some chronic life-altering condition, and you have a high deductible plan, you can end up with very, very, very high medical bills. So that's something you want to take into consideration. Predeterminations. I threw this in there because sometimes people sit with their doctors, and this is, probably something that's going to be really helpful for patients who receive something like a cancer diagnosis. What predeterminations allow you to do, though we are trusting our providers and we're trusting their recommendations, we also know that there are a ton of options, a ton of different opinions, second opinions, whatever, before we just go knee deep into absorbing exorbitant medical cost. Predetermination letters allow you to really look at the medical necessity criteria. So it's something that is sent from your provider's office generally to your insurance plan saying, this is the treatment plan that we are recommending. And then they can kind of give you, as the patient, the information to say, yes, this is medically necessary. This falls in line with what we feel is reasonable course of treatment for your diagnosis, et cetera, or the opposite and say, no, there are doctors at insurance companies that will look and say, no, that's not the American Medical Association's recommendations for this type of diagnosis. So that option is out there. It's not something that I see very often, but again, I'm not really as intimately involved with that. But just kind of wanted to throw that out there from a patient standpoint, that is something that is available to you. Prior authorizations, they kind of work the same way. But prior authorizations are generally done on diagnostic services. So what it is like I said, kind of working the same way in determining medical necessity, but it's really the provider and the facility's way of letting your insurance company know this is the procedure that we want to have done, and your insurance company basically locking it in and saying, yes, we approve for this procedure to be done. And in some instances, it's not negotiable. There are some procedures, some diagnostic testing that has to be prior authorized. And then there are some that, they kind of go out there just to make sure that you as the patient won't have issues on the back end. So really it's about reducing your risk. But kind of wanted to throw that out there because when your provider starts talking about a plethora of diagnostic tests, I say always ask about prior authorizations. Actually, even for treatment, there are some providers, not providers, there are some insurances that will require prior authorization for chemo or cancer treatment. So I know there are a lot of people who have probably gone through quite a bit of treatment and know exactly what I'm talking about, and may have even found themselves on the waiting end of a prior auth coming in for approval before they actually scheduled a procedure. So it's not a bad idea to always ask these questions. Is it something that my insurance company will cover? If they're not able to say yay or nay, ask for the predeterm or the prior authorization to be done before you guys go forward. Any questions here?
No questions.
Okay. So you had your treatment, everything is done. You've seen your provider, did everything they told you to do. You scheduled your appointments, you're all done. And what happens is you will then receive an explanation of benefits from your insurance. So I'm really talking about denials. I talked to you about how to avoid denials, but I'm talking to you about what happens if you actually receive a denial. So you'll get an explanation of benefit, and your insurance company kind of codes these out. And they fall under very general topics like not medically necessary, not covered, patient responsible, things like that. So if you've ever looked at your explanation of benefit that comes directly from your insurance company, you get a copy, your healthcare provider gets a copy. Generally, they'll get a copy with their payment and saying, hey, this is the portion we're paying. They use that explanation of benefits to add in the contractual adjustments or whatever, or they'll also even kind of put on your on your services in their system, if there was a denial, why it was denied. So it's kind of important to understand why it was denied. So if something is denied, is not covered, then that's usually something that your providers or the facility will come after you for and say, hey, your insurance company denied it. This is when you want to ask the questions. Why? You can go back and reference your own explanation of benefits. If it says it's not covered, yeah, they can come after you, ask for your payment, ask for a payment. But if it's something else, if it's non-covered and it's generally something that should be covered, let's say you receive an explanation of benefits for a non-covered physical, your annual physical, like you can get your physical once a year. Screening, no problems, no issue, or you went to the doctor and you just had an office visit and it was a problem and they put the proper diagnosis on it, just billed you for an office visit. If you find yourself getting denials for those types of things, I do encourage you to push and ask more questions, even if it's a diagnostic test or a treatment that your provider recommended. If it's something that's, deemed as non-covered, please push, ask more questions, because what can typically happen is someone made a clerical error, someone didn't put the correct reason for your service on your claim before it went out the door. And sometimes those things can be caught and corrected and resubmitted to the insurance company, which will save you the burden of having to pay for those bills. Excluded. So I want to talk about excluded versus non-covered. An excluded service is something that is never paid. So generally it's a cosmetic type of procedure, but if it's something, and I have seen instances where something was excluded because it was too new. It wasn't like approved or recommended by the World Health Organization or the American Medical Association. So it's still kind of lingered as something that is excluded. So I'm talking about that also in the non-medically necessary arena as well. So long before providers are actually using a standard medical practice, there's research before that. So I know a lot of people don't like to hear the word research, kind of makes them cringe a little bit, like don't experiment on me. I do want to say that without research, without experimental treatment, we are not able to get to the realm of actually knowing what is the standard or recommended practice for fighting any disease, any ailment, surgery, any sort of treatment. Everything that is done as a standard treatment today started out as experimental. So there had to be a group of patients with a specific diagnosis that were willing to try a certain medication or to undergo a certain line of treatment or to have a certain surgery. You guys hear those ads. If you're a person that falls within this criteria, we will give you free medical care if you are willing to be a part of our medical research. So research is very important. We don't get to cures if we have no research. So there may be a very good procedure that your provider might recommend to you that sounds so amazing, so promising, but it could still be in the experimental treatment phase, and your insurance company may not cover it. So if it's something that they're still doing research on and it's being funded by a grant, you should never be asked to pay out of your pocket for an experimental treatment if you are signing up to be a part of the research project. They're generally given funds, like I said, through a third party that would cover the actual treatment. Now, there could be diagnostic testing, labs, and things like that associated with your treatment that are kind of work hand in hand with the recommended research project that they will send to the insurance company, because it keeps the dollars that they need to use for the research going directly to the research, and that whatever services your insurance company would normally cover, they would still send those out. They're called standard of care services. So your office visits, your labs, your diagnostic testing, things like that, standard of care would still go to the insurance, but the actual procedure itself that's considered research would not and should not go to your insurance, would not and should not be paid out of pocket by you unless you agree to it. My last point on that is to talk about appeals. So let's say you have a service that was denied by your insurance. Your doctor says, hey, I don't know why they didn't pay for this. There's everything went out to the insurance company correct. The service went out correct. The diagnosis went out correct. Your insurance information is correct. Everything is correct, but your insurance company is saying no. We don't think this was medically necessary, et cetera, et cetera. We encourage you to work with your provider and have them to write what's known as an appeal letter. And what they're basically saying is, this is why we made the recommendation of treatment. Again, insurance companies have medical doctors on their, that work for their organizations, just like the hospitals do, who can pull notes, read records, ask for additional information, and make a final determination, yes or no, whether or not they actually end up covering a procedure. Most of the time, what I've seen in terms of appeals, it does usually do the trick. Again, unless it falls under something that's excluded, never ever covered, or probably still in the experimental phase, which again, I encourage you to work with your providers and the facilities, especially if it's something that's just too exorbitant for you to pay, for them to kind of help take care of what those costs are. Any questions right there?
No question.
Okay. So I want to talk about the different places of service. And I wanted to bring this up because, post-COVID, healthcare treatment itself has changed drastically. I've been in healthcare for 32 years. And what I have seen in terms of healthcare treatment and options, et cetera, has grown exponentially. So I kind of want to talk about this because it does really play a large impact on you, the patient, what you can end up paying out of pocket, what's covered, what's not covered, what's recommended, what's not recommended. It just gives you some tips and tools. So this is really important. There is a difference between your doctor's office versus a hospital-based facility. Now, you can see your doctor, but it could be a hospital-based facility. So I want you to kind of know the difference. So a doctor's office means he is only going to charge you for his services. You come into a doctor's office setting, the doctor is probably responsible for the overhead, the staff, the supplies, things like that. And so all of the costs associated with your care roll back up to that doctor. You get one bill, it's clean, you pay your copay, you're done, life is good. But if you see your doctor at a hospital-based facility, which is Cleveland Clinic, and UH does have some too. UH does have some hospital-based doctor's offices, considered doctor's offices. And the way you can know the difference is where you see them. So generally, if you see a provider and they're like in some plaza or some medical building, usually it's a doctor's office. If you see your doctor, his office is in some sort of hospital building, a larger clinical setting, or a hospital-based setting like a HUJA, Cleveland University Hospital main campus, anywhere at Cleveland Clinic, actually, these are considered outpatient based facilities. And the reason why it's important to know that is because when you are billed by both what the doctor has done and what the hospital considers their cost. And if it's a hospital-based facility, the hospital is responsible for the overhead and the staff and all that other stuff. So they're billing you separately from your doctor. The doctor will bill you for the visit or whatever it is that he is providing, whatever service he's providing, but the hospital is going to bill you for that room and that space and the time that, that staff has spent with you. So and I'm not saying this to say that these services are not covered, because your insurance company would generally cover them. But I do want to say it from a patient bill perspective, because you would see two separate bills. You see one for the hospital, you would see one for the doctor. Sometimes there is out of pocket, depending on your insurance plan, for both services. So in addition to the copay that you would give your doctor, you would have some sort of copay or out of pocket for the hospital-based services as well. Not saying you will, but I'm saying you could. So I just want to make that make that known to people as well, who are the smart consumers and would rather see their doctor at a doctor's office facility. Urgent care. So urgent cares are, how am I doing with time, Sherry?
We have 15 minutes.
I have how many minutes?
15.
Oh, let me speed it up. Let me speed it up. Okay. Urgent care is non-life threatening. So generally it's so small. I have a UTI or something like that, something that you don't have an appointment with your regular doctor, but you need to be seen right away. And I will throw out that there are some urgent cares that will ask you to schedule, because they can get very, very busy. But they'll ask you to schedule something that same day so that they can, get you in and get you out. Urgent cares are my personal recommendation over an emergency room. An emergency room visit can kind of get you into that high deductible, high out of pocket, hospital-based type of service, where your urgent care is typically works the same as your doctor's office, where you're paying your copay. It's a minor procedure, non-life threatening, and you're good. The way you can tell the difference, and this is what I would recommend, if your symptoms may require hospitalization or maybe life-threatening, you want to go to the emergency room or call 911 to have them pick you up. If it's something that you can drive yourself to the doctor, go to the urgent care. Go to the urgent care. That's how you know the difference. And since COVID, we have gotten into the world of telemedicine. Telemedicine did exist prior to COVID, but COVID made it, it just made it way more popular, because what it did was it cut down on the face-to-face interactions. Patients loved it, but I think some people got a little bit confused, because they thought because they were either talking to their doctor on a telephone or talking to their doctor via the computer, that they wouldn't have to pay. But that's not true, because the doctor is still providing you a service. So a virtual service is just that. It's an interaction like this between you and your doctor. Generally, what your doctor would do is charge you the very same service that he would have charged you had you shown up to the office in person. Generally, these are, you don't require blood work. They have you take some semblance of your own vitals, like if you have a blood pressure machine at home, they'll have you, kind of read your blood pressure, things like that. So they'll take some sort of vitals that are required for your visit. But the virtual care visits are really nice. I think we have kind of gone down a lot over the past few months in 2023 with the end of the public health emergency, but they are still an option and still very popular for some very, very sick patients, some of our elderly patients, et cetera. Phone call visits, same kind of aspect as a virtual visit. but there's not the face-to-face. It's just a conversation. Every time you pick up the phone and talk to the doctor doesn't necessarily constitute a phone visit. The way you can tell is if your doctor's just calling you with the results of something, it's probably not going to be a charge. But if you're actually you're conversing back and forth, and the doctor has to pull records, in order to answer your questions, maybe it turns into more like a counseling type or conference type of thing. He or she may charge you for that phone visit. Phone visits are time-based. So if you ever receive a phone visit bill from your insurance or your doctor, you could actually look on there and tell how much time. So I would recommend that if you just one of those people who watch your pennies and you don't want to be overcharged, attention to how much time you spent on that phone with that doctor. An e-visit is usually it's email, but it's like it's an exchange. It's not one email to your provider and they respond, but it's usually an interaction. A lot of these are paid up front. You have a flat fee. You can do them through My Chart, Follow My Health, however that goes. But you can, kind of message a doctor. May not be your doctor, just want to let you know that. But you would message a doctor. He asks you a question, you answer the question, he gives you a response. So there may be a little bit of a back and forth, and it could go over for a period of several days. And they will give you a medical recommendation. So some people really like that because they're really busy. They don't want to go in. They may not have insurance. But again, this is only recommended for some minor procedures, something really acute, something that's not going to require medication or things like that. So it's a really good option if you so choose. Wait a minute. Okay. Really quick, patient statements. You should receive statements from your healthcare provider if there's any out-of-pocket cost associated with you. They don't generally send you statements unless you have a portion of that bill that belongs to you. I urge you to compare that to your EOB, your explanation of benefits. As I said, you would always and should always get an explanation of benefits from your insurance company anytime you see the doctor, or any treatment that you have in the hospitals, laboratory tests, diagnostic tests, blah, blah, blah. And their explanation of benefits from your insurance company basically says what they paid, what they didn't pay, and why. So make sure you're doing that comparison and doing that homework if you actually receive a bill. I wanted to throw price transparency out here because it is regulatory for all medical facilities to post or publish what their prices are. So under no circumstances should you ever have a service that someone cannot give you an estimate or quote to you what your bill could be. And when I say estimate, an estimate is only, so the person who's giving you the estimate only knows what you're scheduled for. Now, if you are scheduled for a service and you go in and you see your doctor and your doctor says, I want you to do this service and this service, that's going to change the estimate that you received ahead of time. So please give that grace when you receive your bill and say, no one told me this. But if your doctor made a recommendation, get a new estimate. Don't go off of what you were given initially. As your services change, make sure if it's something that you need to know that you're getting those services quoted to you in estimated form, because they only know what they know at the time, that you're getting as much information ahead of time. An ABN versus a waiver. So an ABN is something that Medicare requires. An ABN is an advanced beneficiary notice, and it basically says that if you are given a service or treatment recommendation, that if your provider knows that there is a chance that it will not be covered or may not be covered, that they are obligated to inform you of that risk and also give you an estimation of what that cost could be. That is for medically inclusive services. So excluded services, they don't necessarily have to give you that notice, because you should know what's not covered by Medicare. But a good doctor and a good facility will let you know, Mrs. So-and-so, Mr. So-and-so, this is not covered. Waivers kind of work the same way, but a waiver is not something that is obligated. ABNs are regulatory. They have to tell you this is not covered. There's a chance it's not be covered. But under your commercial plans, there are some providers and some facilities that will give you a waiver when they know that there's a chance that your insurance company may not cover it, and it works the same way. Waivers can be optional, so you may not always get them, but I would ask again for the predeterms and the prior auths once you start getting into heavy treatment. Always ask for payment plan options. A lot of hospitals and providers don't have great payment plan options. So the longer you're out there and you don't pay, you run the risk of running into a bad debt situation. Bad debt basically means they'll sell your debt to a third party who will then come after you as a debt, like a bill collector, and say, pay your bill, pay your bill, pay your bill. Sometimes you have more options with them. Because, they want the money. The providers just want to close your debt, get their money, get you off the books. So you don't want to go to bad debt. I'm not making that recommendation, but I just want to let you guys know what the differences are. Prescription plans, coverage may be limited. There is some out of pocket. You can always have your pharmacist run a query to your insurance coverage before you actually get a prescription and walk out the door. Before you pay for it, ask them to run a query so you'll know what your out-of-pocket is. Sometimes patients are even savvy to say, hey, give me the generic brand, because there are some cost savings with generic brands. Pharmacies are popping up everywhere. I wanted to kind of make this note. You have your retail pharmacies, which are like your Rite Aids, Walmarts, blah, blah, blah. You have your freestanding ones. They could be as a part of hospitals. Cleveland Clinic has them, UH has them. But then you also have some other kind of pop-up pharmacies that kind of operate on their own. So just know the difference. Some of the retail pharmacies may not be covered under your large group employer plans. They may have certain pharmacies that you can deal with and certain ones you cannot. So please understand your pharmacy benefits. You have mail order, which may or may not be covered. 90-day supply can also help curb some of your costs. Sometimes those are like automatically refilled, but look at what your prescription options are before you just go ahead and get all of your prescriptions filled. Okay, I got 4 minutes. Diagnostic treatments are your labs, your radiologies, your screenings, your physicals. All of these things are generally covered by, again, most insurance plans, whether it's governmental, commercial, et cetera, et cetera. If your provider is recommending something, and the reason why I put this down here is when you're going to look and research which medical plans you actually select, it gives you a rundown of how these particular things are covered, how your standing order labs or your diagnostic labs are covered, how often you can have them done, what types of radiology, if MRIs are excluded, if they're included under certain circumstances, your screenings like your annual PAPs, your mammograms, your colonoscopies, they tell you the exclusions, the recommendations. So if you know those, that you definitely should be covered. Physicals are something that you can have once per year. It could be either a rolling year or a calendar year. So please know the difference. Treatment options, again, I threw this on there because I want you as a patient advocate to know that just because your provider is making a recommendation to you does not mean you have to do it. Ask questions. ask for other alternatives. If it's something that you're really not comfortable with, you can always get a second opinion. But have conversations, forge that relationship with your healthcare professional, so that you can make sure that you're making the best decision for yourself. Oh, I'm almost there. HCAP. Put this on there, Healthcare Assurance Program, HCAP. And this is really for patients who are underinsured or uninsured, or you find yourself, you once had insurance, but no longer have insurance. These programs are great because they actually, this is your medical facility helping you to get Medicaid coverage if you qualify. If there is no Medicaid coverage that you qualify for within a certain federal poverty guideline, you may be able to get all of your, well, good majority of your medical insurance expense or medical expenses written off without having to pay anything. So that is something, if you find yourself in that situation where your hospital bills are exorbitant, I would encourage you to apply through your healthcare institution and find out what your options are. And I think this is lastly, my spiel on EMTALA. This is very important. Your Emergency Medical Treatment and Labor Act, and I believe it took place back in 1986. But EMTALA is something that every patient needs to know about. Your healthcare provider cannot deny you service based on your ability to pay. So if someone is screening you up front before you even go back, and this is very important if you're at an emergency room or urgent care facility and you're sick, they cannot refuse you service. What they do have to do is at least get you stable. If they may transfer you to another appropriate healthcare facility or healthcare provider, but they cannot refuse you service. If you walk into an emergency room with a life-threatening illness, the first thing out of their mouth can't be, "Can you pay?" They have to get you in, get you stable, triage you, do all the life-saving measures, and not throw you out the door because you don't have any insurance. And some exclusions, and I did put cosmetic, uncompensated care, or a non-compliant patient on here. And this is really important because your doctor's office may ask you to reschedule if you no longer have coverage, or if you're a patient, they can actually excuse you from a practice if your bills are exorbitant and you're just not being compliant and not making any payments. So there are some exceptions to EMTALA. I did want to just point out to you that if you have to be seen, if it's a medical emergency, they have to treat you, they have to stabilize you and get you to the proper facility after they stabilize you, if they're not able to treat you there. I think that's all I had, Sherry.
I do have a couple of questions.
Okay.
I was just making note as you were talking about it and thinking about different scenarios.
Okay.
So when you have a diagnosis and you want to get a second opinion, how does that fall in the payment aspects? Are second opinions always covered?
Second opinions are not always covered. So here's where we fall into and this is kind of a cheat code for you guys. So listen up. It depends on if it's determined to be a consult. So consultations are an actual thing. A consultation is very different than a new patient visit, or office visit, et cetera, et cetera, et cetera. A consultation means that one provider has made a recommendation to another provider to see you for a specific service, to give recommendations, not necessarily to treat you, but to give recommendations. So it has to be like a written notice or a verbal notice or something like that, where they say, "I'm sending Sherry to you for you to let me know what's going on with her, this particular condition." Now that's a consult. Now, where it gets a little bit tricky in terms of not being covered is there are people who fall under the category where they're self-referring. Like if I just say, I'm gonna go to see Dr. So-and-so, so-and-so, and no one sent me to Dr. So-and-so, so-and-so. And that doctor is trying to classify it as a consult and saying you're self-referring. That is something that is considered out of pocket, completely out of pocket. What I would recommend you do is say, I'm coming to you as a brand new patient. I'm not going back over to Dr. So-and-so, so-and-so. I'm coming to you as a brand new patient. I want you to take over my care. And then it's not a consultation, self-referred type of situation. You can take all of your records and go wherever you want to go. But if you're going to hop back and forth between this provider and this provider, and you say to this provider, well, Dr. So-and-so, so-and-so said this to me, but I don't believe it. I want a second opinion. They may charge you a consult. They may, because it puts them at risk for not being able to take over your care, but they've essentially seen you with a life-threatening illness and may never see you again. Does that make sense?
Yes, it does. Thank you very much.
Okay, you're welcome.
The other question I have is, some of our sisters, cancer springs itself on you. You're never really prepared. And sometimes someone may be in between jobs and they get this high medical bill, or they may be sent to collections. What options do they have?
So that's where I would say the HCAP is something that you want to look at. So HCAP it really is for the patients who are uninsured or underinsured. So if you're unable to work and you no longer have coverage, you're definitely uninsured or underinsured, right? So there should be options available for you. The first step is for them to look at if you qualify for any Medicaid coverage. If you don't qualify for any Medicaid coverage, the HCAP is a program that gives the facilities X amount of dollars to write off your bills. So they're not going completely unpaid. They're just taking an exorbitantly lower amount because you yourself as a patient are unable to pay. Then it could be, let's say the bill isn't into the thousands of dollars, just several hundreds of dollars. Then I would ask that facility, well, hey, I don't have $500 to give you today. Can you set me up on the payment plan? Just ask. You won't know unless you pick up the phone and ask the questions. You don't know what they have. There could be grants. There could be instances where they completely write it off and say, you know what? They didn't bill that right, or something else is going on. And let me talk to the doctor. I've seen it happen. But under no circumstances would a person be expected, or should a person be expected, to pay a medical insurance bill if they're not working, over caring for their physiological needs. The hospital should not kick you out. The hospital should no longer refuse to treat you. If you're dealing with a certain diagnosis, I guarantee you that whichever facility you're in, they're going to work with you. The doctors don't care. They don't care if you don't have insurance. They're going to continue to write out your treatment plan and treat you without knowing or caring about any of those things.
All right. And this is my final question, seriously.
Okay.
I sit on the billing side of healthcare. Thank God. Thank you. But I often hear, so one thing that you have mentioned was when you're doing a telephone visit, it's timed, or you're pretty much charged by the time that they spend on you on the call. Does the same thing exist for inpatient visits or in-person visits?
Yes. So in-person visits, so it gets a little bit tricky because it depends on how the doctor documented that visit. So the doctor has the option to say, I'm going to charge you a higher level visit, like a level 5 visit, because I spent a whole hour with you, and bill you based on time. or he can bill you based on medical decision making or the components of your visit. So if your person, and this is a conversation I have with the doctors every day. So if you're treating a patient who has, let's say all a person has is a UTI. It's a acute service. You go in, you run a dip, you take their vitals, blah, 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 blah. It's a low level, straightforward visit. That's not going to be a high level visit. It's going to be a level 2 visit, in and out, you're done. But let's say you see your doctor once a year, every 6 months, or you're having a problem and you schedule a visit with the doctor. However many issues that provider evaluates usually determines the level of service he's going to bill you for. So if he sees you and he has to talk to you about your hypertension, you're not doing well, your blood pressure is up kind of high. Oh yeah, I saw this scar on my knee. He looks at that. He gives you a referral to dermatology. Oh yeah, you're doing well on this medication. We're not going to change it. You keep doing it as recommended. Everything looks great. So there's 3 different things that he's talked to you about. And then you know what? While you're here, I'm going to just do your annual physical. I'm going to order your annual labs. I'm going to give you a rec for your mammogram, your regular screening. That's a separate visit in addition to your problem visit. So the levels of service actually it is determined based on how that provider chooses to document. So they can go basically, hey, these are all the conditions we talked about. This is the services that I provided. This is the level of service that's appropriate for that, or basic completely on time. Like I spent 30 minutes with this patient. We talked about this, we talked about that, and that's a specific level of service.
All right, now you opened up another question for me. What if you're meeting with the doctor, you're only with them for 5 minutes, but the documentation that they wrote doesn't match actually what actually happened? What will be something that a patient could do to correct those things?
So I will say this, because that's common. Well, I don't want to say 5 minutes is common, but what I would ask you to consider is there is pre-work done. The good doctor is doing pre-work. So you go to the doctor. There are some doctors, and Epic kind of makes this a little tricky because sometimes they'll start the note and patients don't show up. So they go in, they open up their note. Sherry's here today for this. They look at your last note. They look at your medications. They look at, oh, you know what? They can see that you had labs done, or they can see that you saw Dr. So-and-so. So they're prepping ahead for your visit. That time is included in your visit. That prep time is included in your visit. So I ask you to consider that. And I know for a fact that a majority of doctors are doing that. Nobody's walking in the door like, I didn't know it was you, Sherry. They're looking at your notes ahead of time. Some doctors that have MAs that work with them who are coming in and taking your vitals, and they're going to ask you, hey, what brings you here today? And they'll put the reason for your visit in there, and they'll put some notes based on what comes out of your mouth. The doctor's going to look at that before they walk into the room. Not going to be sitting there looking at that computer when they're in the room with you. They've likely done that before they got there so that they can focus on you.
Sounds good. That's all the questions I have. Yeah, I'm ready to go to work.
Good. Awesome sauce. You call me anytime. Oh, I put a couple of resources up there, so I didn't just make this stuff up off the top of my head. But if anybody wanted to reach us directly or had any questions, you can still reach out to us about it. Sure. Do you have any questions for me?
No, I think I'm good. So, hey, everybody.
Hey, and she can vouch for you as a medical provider that she's looking at them notes before she walks in that room.
Yeah, we try to, so we can know, like, especially if you're coming for a maintenance visit, or if you're not, Like for instance, if we hadn't seen you in a couple years and we know you're due for something, then we want to try to address that with you while you're there. Things of that sort to make sure you stay up to date.
I hear from or see from a lot of patients' perspective. So I see a lot of complaints on my end. And it's always the doctor's running late. The doctor's running late, only spent 5 minutes with me, didn't ask me any questions, but I get this huge medical bill. So what should they do? Is there any cross documentation? So getting access to their My Chart will be useful. And then looking at their bill?
Absolutely.
Sorry, go on. Go on, I'm sorry.
Okay. So yeah, absolutely. Looking at your My Chart is great. But what you also can do, you can call the customer service department and say, listen, this doctor didn't do that and so, that's and so, that's and so. They usually will have someone outside of that practice review the documentation and say, yeah, that's kind of high. That documentation doesn't support that. And then make any changes that are necessary and rebuild the insurance, or explain to you why it is correct. It is absolutely, as a patient, as a consumer, your right to ask or challenge the bills.
But I just want to add to along that, a lot of patients don't understand what we do. Like when somebody walks into my office, I'm already doing an assessment of you. I'm already looking at your skin, making sure that you don't look pale, that your mucous membranes are moist, I'm already doing an assessment of you without even touching you. So some people who don't believe that goes into the assessment piece, that you're at rest, you're not in any distress, you're not using accessory muscles to breathe, you're not using, all these things that they're like, what the heck is she talking about? But this is stuff that we've been trained to do, trained to assess for. I could do a lot of things as far as assessment without even putting my hands on you. And that's a good practitioner who do those things. Some people do chart with, don't have good charting practices. I don't know. But I know for myself, I don't chart things that I don't do. So I do my assessment on the patient. Some things that they don't think that I did, I do. That you may not know or you may not see from my point of view, but it is done. And if you want to question that, then that's fine too. And then some people, they just don't understand. Like I had somebody who came into my office and she wanted to have a PAP done every year. Well, again, our guidelines changed. And she said, well, this is important to me. And she was almost in tears because she said that, ovarian cancer and uterine cancer run in her family. Okay, I appreciate that. But when we're doing a PAP, we're testing for cervical cancer, which is caused by HPV. That's not familial. That doesn't run in families. That comes by exposure to sexual intercourse. So again, it's all about the education part as well.
Mm-hmm. Yeah, and that's a great point that Lavada made, and it goes back into what I was saying in terms of non-covered or exclusions and understanding what you, as a patient, have coverage for. Because yes, that was something that was done. I used to get my annual PAP and pelvic exams done every year, but not so much. Like unless you've had an abnormal, it's not something that your provider is going to recommend or even do every year. Very different from a physical. You'll get your physicals, but it may not include a pelvic. Is it 3 years or 5 years now, Lavada? Help me. I'm not an OBGYN anymore.
So it all depends on your age and also your results. So if you're under the age of 30 and you just have a pap smear and it's normal, then it's good for 3 years. But once you're 30 and over, we automatically add what we call co-testing or the HPV, or most providers do. It's recommended, but it's not absolutely certain that you have to do it. But most of us will go on and add that co-test. So if you have the PAP and that's negative, that's already good for 3 years. But when you add the HPV testing with that, and again, human papillomavirus, It's the virus that will cause abnormal cells on the cervix that could become precancerous or abnormal cells that could turn into cancer. Then that, as long as that is also negative, then that extends it for an additional 2 years for a total of 5. So again, it depends on your age and your results.
Hi, Kel. She was just coming for moral support.
Hi, y'all. I'm sorry. I was trying to come on mic because I'm running a vacuum.
She was here for moral support. That's what I said. All right, Sherry.
Well, I appreciate you taking the time out to prepare this presentation. It was very enlightening. I've learned a lot, and I saw a bunch of hearts come up online. So I'm sure everyone loves it as well. So we'll put this on our site so we can refer back to it. And if anyone has any additional questions, just reach out to My Sister's Keeper.
Yes, I'd be more than happy to take additional questions or give some recommendations to anybody who's struggling with those medical bills or have something that they don't quite understand. So I'm here. Thank you so much for having me. This was good.
Thanks again.
All right, y'all. Have a good rest of your day.
Okay, I stopped the stream.